Lovely.
Hello everyone, I've just spoken to Anna and I think we're nearly ready to go live apparently, so we can go ahead.
Yippee! I think some of the, I mean, at my surgery, we sort of got ordered off. You will go and have your first jab on this date at Peterfield.
Yes. Excuse me, members, the meeting's now live and apologies for the delay.
Thank you, Anna. So I'll make a start. Afternoon and welcome to the Health Overview and Scrutiny panel. I'm Councillor Ian Holder, Chair of the panel. Members of the public are invited to view this meeting online, and those present are requested to keep their microphones on mute and to only turn them on when they are called to speak. Members are requested to keep their cameras turned on at all times. Officers and external presenters are requested to turn their cameras on only when they are presenting their reports or answering questions. If anyone would like to speak, please write your name and RTS in the chat function. And each time you speak, please say who you are so it's clear who is speaking. I'd now like to invite those present to introduce themselves, members, then officers and external representatives. So if we can make a start, Councillor Lee Mason.
Hi, Councillor Lee Mason, Gosham Ward.
Thank you. Matt Atkins was here, but unfortunately he's had to leave. Judith Smythe is not here, but she's not sent any apologies. Councillor Rob Wood.
Councillor Rob Wood, Deputy Lord Mayor and representing St Thomas Ward in Portsmouth.
Thank you. Councillor Arthur Agates.
Thank you, Chairman. Arthur Agate, I am the East Hants District Council representative on this committee.
Thank you. Councillor Anne Briggs. Is Anne still with us? No. Councillor Lynn Hook.
Hello, I'm Councillor Lynn Hook. I'm representing Gosport Borough Council. Also, I'm the Mayoress of Gosport this year.
Thank you. And now some of the external representatives. Jane Ansell.
Good afternoon, I'm Jane Ansell. I'm the Senior Responsible Officer for the COVID-19 vaccination programme for Hampshire and the Isle of Wight.
Thank you. Derek Sandman.
Hi everyone, I'm Derek Sanderman. I'm the Chief Medical Officer for the Hampshire Isle of Wight ICS.
Thank you. Helen Atkinson.
Good afternoon, Chair. I'm Helen Atkinson and I'm the Director of Public Health for Portsmouth.
Thank you. Nikki Creighton-Young.
Good afternoon, everybody. I'm Nikki Creighton-Young. I'm the Director of Operations for Southern Health NHS Foundation Trust.
Thank you. Paul Gray.
Hello everybody, I'm Paul Gray, Director of Strategy in the Hampshire and Isle of Wight Integrated Care System.
Thank you. Dr. John Knighton.
Good afternoon, I'm John Knighton, I'm the Medical Director at Portsmouth Hospitals.
Thank you. Mark Orchard.
Good afternoon everyone, I'm Mark Orchard, Chief Financial Officer at Portsmouth Hospitals.
Thank you. Joe York.
Hello. Oh, sorry.
Hi, I'm Jo York. I'm Managing Director of Health and Care Portsmouth, Portsmouth CCG and the City Council, and was asked to attend for items 5 and 6 in case there's any local questions that I might be able to help answer.
Thank you. And Anna from Democratic Services.
Yeah, Anna Martin present.
Thank you. And is there anyone I haven't called so far? I think that's everyone. We've had apologies from Councillor Roger Bentote, Trevor Cartwright and Rosie Rains, who've sent their apologies today. I'd like declaration of members' interest next. If any members of any interest to declare, please put RTS in the chat box and I'll call you to declare an interest. Does anyone have anything to declare? No. Perfect. Right. Minutes of the previous meetings. Do I have a proposer and a seconder for the approval of the minutes? Rob? And anyone else to second it? Lynn Hook, thank you. So those minutes have been approved. So we'll go on to the presentations. Just to let you know, once you've done your presentations, you know, there's no obligation to stay for the rest of the meeting, especially as we're running a bit late. So as soon as you're done, if you want to go, then feel free to go. I'd like to move on to item 4 on the agenda, which was Portsmouth Hospital NHS University Trust, and I'd like to invite Mark Orchard and Dr. Knighton to give a brief update on the report and let us know if anything's changed. Thank you.
Thank you very much, Chair. And Mark, I think if that's okay, we'll stick to Plan A, which was I'll give a quick summary overview of the situation in the hospital, and then move on to Mark, who is going to give an update around specifically the progress and the plans for the emergency department redevelopment. So you will have all councillors received the report, so I'm certainly not going to go through that again. I'm just going to highlight one or two things that perhaps will make it a bit more up to date. You will probably already, I'm sure, know that whereas our report says that we were seeing a rising prevalence of COVID in our community, which was true until 2 to 3 weeks ago, that is now not the case. The COVID community rate is falling, and in parallel with that, although lagging behind it, the number of hospital admissions is also falling slightly. So as of today, for example, we have 63 inpatients with COVID in the hospital. 3 weeks ago, we had 83. And that was about the peak of the number of COVID admissions we've had this time. We haven't seen as yet, and hopefully we won't now see any particular surge as a consequence of the Victorious Festival that I think we were all anticipating might have had an effect. But we have seen a sustained impact on patients needing higher levels of treatment, whether that be through some non-invasive ventilatory support, CPAP, in our respiratory high care unit or in our intensive care unit. You will probably also be aware, but I'll just give you perhaps a slightly more colourful illustration of exactly how busy the hospital is with things other than COVID. So we were in fact running last week at an overall hospital occupancy of over 99% average. That's an almost unheard of level, even for the depths of winter. And it reflects, of course, some impact of COVID, but also the presentations of patients with so many other conditions. We've seen the attendances at our emergency department, both walk-ins and ambulance conveyances, have been rising steadily since around April and continue to rise. The number of admissions consequent on those attendances has also continued to rise, and sadly reflecting some of the challenges in the community with post-acute care. The numbers of patients who we identify as medically optimised and waiting therefore for some additional support out in the community has also risen up to nearly 150 of our patients today. So the pressure on the trust has been very unusual and quite extreme, particularly for this time of year. That notwithstanding, we have been working hard on increasing our elective, our non-emergency output. Our target was to get to and exceed the 1920 baseline of elective activity, and we have been achieving that despite the emergency pressures, and that's largely because, as some of you will be aware, we operate our elective capacity through a very small proportion of our inpatient bed base. We are continuing to meet the majority of the cancer targets, and that's again despite the pressure. So our focus now is on maintaining as good as possible a flow of patients through our organisation to minimise the delays and to hopefully improve the experience of patients, because we all know that it's not good waiting for anything, and there are a lot of people seeking treatment that are struggling to find the treatment that they need. We are about to undertake, following the directives that are starting to come out from the centre now, our booster dose vaccination programme in our workforce as directed, and we already have over 93% now of our workforce who are fully vaccinated and will be receiving their booster doses in the same way as the general public at 6-month intervals after their completion of vaccination. And I guess probably just for my last point to finish up and see if perhaps there are any questions around that before passing on to Mark to talk about the emergency department, just to highlight the impact on staffing of the sustained pressure that we've had coming out of the wave of COVID. You will all remember only too well that Portsmouth Hospitals had one of the busiest and perhaps most difficult, certainly numerically and in terms of impact, COVID caseloads to manage through our hospital. Over 60% of our inpatient beds were full of COVID patients at one point in February. There hasn't been the rest and recuperation that perhaps we had hoped we might be able to offer our staff over this summer. And as you would normally get in a normal summer, to be honest, it has been an incredibly busy period. We have prioritised our staff getting leave, and we have given them all an additional wellbeing day. And the offer and the support we're offering to our staff to try and ensure that their well-being is looked after, and we retain staff coming into this next winter, because that is clearly a priority to maintaining our business continuity and the service to patients. But I think you will recognise that that is an ongoing challenge. I'm going to pause at that point, or in fact I'm going to stop at that point and see if there are any questions you would like to ask of me before I pass on to Mark.
I've had requests for a few questions. Councillor Arthur Agate.
Thank you.
Take myself off mute. Thank you, Chairman. The opening of the urgent treatment centres, has that how has that affected your current operation?
Very good question, actually, because there are complexities around the functioning of the urgent treatment centres, and one or other of them haven't been able to maintain the full operating hours that they were planning to do, largely through staffing difficulties, I think, and that has had a negative impact on us. We have seen over recent weeks, in the last 6 to 8 weeks, we have seen some increases in attendances in the emergency department at QA through the evenings, when the urgent treatment centres have had to reduce their hours, particularly down at St Mary's. So they are an important part of the provision of urgent care. You're absolutely right in the premise underlying the question, and when they haven't been able to be operating in their planned scheduled hours, that has had an impact on us, an adverse impact.
Presumably something's in process to improve that.
So we're working really closely with all the other providers. We have meetings on a daily basis with all of them at all sorts of different levels through both organisations, or all organisations, I should say. Their challenges are particularly around staffing, and they're not easy to resolve, but they are clearly committed to that. It may well be that other models of providing urgent treatment centre operational function and capacity are going to have to be looked at over the next few months as well. So a different model potentially, or even different locations.
Thank you very much.
Thank you, Councillor Wood.
I put it in there. Basically, John, thank you for that. I understand how we've got to here and what you're doing today, but at some stage, what we're really after in plain English is if your plans, if the capacity, i.e. people coming in, exceeds your capacity to manage it, what will you be doing? What I'm trying to understand is there's going to be, you can increase your capacity, but there'll come a point where maybe you haven't got enough staff or what have you, and you haven't got that. What will you do? Will you do similar to previously, which is swap those from, the acute things you're dealing with and swap it over to another area? Or will you stop patients coming in, or what will you do? I'm just trying to understand what's ultimately possible if you've maxed out.
Yeah, thank you for the question. It's a really difficult one to give you. I think the sort of answer that you really want, which is some assurance with a little bit of convincing detail underlying it, isn't it? And because the reality is that at the moment the demand is rising, it's continuing to rise, and it is outstripping capacity. The answer to that is to do everything that we can do on all of the different fronts that will make a difference. There is no one thing, of course. It is, as always, it's going to be marginal gains on a number of different fronts. But for example, some of that is going to need to be managing demand at our front door differently. Some of that is we're going to have to try again, working with partners, with primary care and with all the other providers, to wherever possible direct the people who don't really need an acute hospital to support elsewhere. We are going to have to make sure that all of our internal processes are as slick and as good and as effective as they can be, to waste as little time as possible. And we absolutely need to make sure that the number of patients who are ready to be discharged because we have finished treating them, but they need an ongoing package of care or some sort of support, are able to get that in a way that doesn't impact our ability to admit the next patient. Because you're right, if we can't make enough capacity through doing all of those things, there can only be a knock-on consequence to elective activity. The only thing I would say is that we have been and we will be continuing to try at almost all costs to avoid affecting the elective capacity, partly because it doesn't gain us a huge amount more, if we're honest, in terms of space, because we operate through a relatively small proportion of elective bed base, as we would describe it, in our hospital compared to many. And even more importantly than that, the elective work that we're doing is quite carefully and rigorously clinically prioritised, meaning that those patients that we are treating on the whole need to be treated, and we're all aware of the escalating backlogs across the country and the patient experience that sits within that, as well as obviously the potential risk of harm. So we will continue to prioritise cancer care no matter what, and we will be doing everything we can do to minimise the impact on elective planned work. But there may well come a point at which that is inevitably compromised.
Thank you, John. Really, all I was trying to do is set the expectation of the public of where you try to mitigate circumstances. But ultimately, at the end of the day, clearly, if your capacity is reached and exceeded for sustain, something somewhere has to give. And I just wanted to give you an opportunity to place that on record so people know.
Yeah, thank you very much.
Thank you. Were there any other questions? No, then should we move on to Mark?
Okay, thank you, and thank you, Chair. With your permission, we agreed in advance that given the nature of this particular aspect of the update, it'd be really helpful to have a visual presentation, albeit short, just to sort of bring to life the new emergency department. So I'm going to attempt to put that on screen now, if that's okay. Just while that's loading up, you'll be aware that a couple of years ago now, the Secretary of State for Health announced that we were going to get the investment required to enable us to build a new emergency department here at the Queen Alexandra Hospital. Can I just check that you can see the slides in front of you there? Okay, thank you.
Yes.
Perfect, thank you. And so I'm going to just give a visual overview of some of this, and then obviously invite any questions as well. So you'll all be aware the existing emergency department here at Queen Alexandra Hospital is some 40 years old. So it was one of the departments within a building that we were unable to build as new when we brought the new PFI hospital to the site, which has been operational now, believe it or not, for 11 years. But in that 11 years, we haven't seen significant building development on the site, but we're now in a period on the site where we are seeing a number of interconnected developments that really enable the Queen Alexandra Hospital to be fit for the future in terms of the demand that is continuing to rise, as we've just said, but also predicted to continue to rise. And therefore this development, the emergency department, is one of a number of developments that have had the support of the planning committee. Thank you for those who sit on the planning committee in order for us to maintain our fitness for the future. For this particular development, the emergency department in particular, we are working to a number of objectives, the objectives of which have been squarely agreed with all system partners across Portsmouth, South East Hampshire, whether that be neighbouring acutes, the community mental health, trusts and providers, and also obviously, of course, the commissioners at Portsmouth and also Hampshire, Southampton and the Isle of Wight. And we've been working for a number of years now, as clearly, in order to develop a specification for the works that will enable the clinical model to thrive, not only when it opens, but also clearly into the future. Where we are on the roadmap to delivering the new build is where you see on the screen there. So we had, there's nationally, for this level of investment, and there's £58 million of national capital investment being committed to this new venture. There's a 3-stage application process to go through to confirm the release of that funding, which is part of the Treasury rules with the Department of Health. We've successfully navigated the first of those 3 stages, and we received the first stage strategic outline case approval in September 2019, just before obviously going into the COVID pandemic. We've continued to work on the outline business case, and we have most recently submitted in July this year the outline business case for consideration by the Department of Health and NHS England and Improvement, which will allow us then to move to the final stage, which is the full business case and then the detailed design. Now, the stage we're currently at is that we've commenced that detailed design, and I'm just going to sort of unfold some of that in a second. But you'll see from the timescales we're working to, whilst this new emergency department won't actually be operational until the autumn of 2024. We will start to see there's a 2-year construction period and some enabling works required as well. So subject to the national approvals, we will start to see the first shovel in the ground, if you like, the first construction starting to happen on the site from as early as next summer. So we really are close now to starting to see this being brought to life visually, alongside some of the other developments that are already progressing on site, which are not the subject of this particular presentation. We earlier on in the life of this development, we consulted on the location options on site. As everyone will know on this panel meeting, we're a very constrained site, so there's not a lot of options on the site in terms of where we were to choose to build the new emergency department. We shortlisted 3 particular locations. We consulted very widely on that, including a lot of people on this health and overview scrutiny panel. We consulted closely with the planning officers, and we've chosen for reasons I can unfold if we need to site the new emergency department on the site that is currently used for a 2-tier car park for staff. So there are alternative arrangements in place, obviously, to compensate for that. But what that means is we're able then to build in an area that will allow us to get to the solution the quickest possible timelines. The alternative options were expanding the existing footprint, which is the option 1 you can see there. That would have come with some significant disruption to the existing service for a period of 2 years and at least 2 winters during the construction, and therefore that was discounted for those reasons and other reasons. And an alternative option was to build in what is the another car park, public car park in the north of the site. But the clinical adjacencies attached to that particular location didn't lend itself to all the internal interfaces behind the emergency department that needed to be geographically close to the proximity of our emergency department. So for all those reasons, we've chosen our preferred option as being the site of the staff car park. It will be a 3-storey development, and we will be retaining some staff parking on the ground level, as well as having mitigation in place for the remainder of those car parking spaces. But the real interest, of course, comes on level B and on level C. And level B, we will be able to build our facility, which is our clinical facility for our majors, urgent care, paediatrics, radiology and resus, as described on the slide, all on 1 floor, all co-located, which will absolutely maximise the efficiency on the flow within the department itself. And on a floor above that, on sea level, we've been able to retain that for staff training, changing and well-being, in terms of ensuring that our staff have got adequate rest areas during their shifts as required as well. So if I just go on then to describe that, so level B is the area that obviously we're focusing on at the moment in terms of our new emergency department and paediatrics. And if you take the floor space that we're, just give you a feel of scale here, the floor space footprint, the physical footprint that we're going to be building into our new emergency department is just over 5,000 square metres. And just to put that into context, our existing department is just under 3,500 square metres. So it's a very, very significant increase in size of department, recognising that our existing department is very constrained, and that brings with it visual impairments as well in terms of the ability of our clinical staff to monitor patients in the way that we would like, and this would obviously correct some of that in the future. I said we're already into the detailed design. This is the outline design that was signed off early on in the year. We've now moved a step ahead of this. So this 1 to 200 scale design, we've already agreed exactly where our rooms and locations will be within the department. We're now at the stage of designing within rooms and footprints within rooms. So we're now at a very detailed design stage, just to give you a sort of feel for that without needing to see the detail. And of course, we've liaised very closely with the planning officers, as I said, and the transport officers in terms of making sure that traffic flow, whether it be through a blue light ambulance, patient transport vehicle, or members of the public, in terms of accessing the walk-in attendances, we've made sure that that is fit for the future and that the flows work from a sort of traffic flow perspective. The illustrations you've got in front of you now on the screen relate to the artist impression, if you like, based on the current design, and you can see what you're looking at there is B level, where the ambulance drop-off area will be, and then obviously the building behind it. And then on the next illustration, that's the walk-in entrance, which is just adjacent to the eye hospital, which sits a level below the existing emergency department on the east of the site. Planning application, we've had a few rounds of the planning application. The outline planning application was fully supported by City Council's planning committee in July. Again, thank you for the councillors here that lent their support unanimously to that application, which allowed us to progress to the next stage of the business case. The clinicians have been clearly involved with this all the way through and sit on our project team that meets at least weekly, formally and informally a number of times to ensure that this design is designed with clinicians, for clinicians and for patients, and fit for the future. And you'll see that this slide tries to draw out some of the benefits here. We've learned from some of the lessons we've learned over the last 18 months or so through the pandemic, and so we're building a department that's got adults and children treated in single rooms, which is not only for privacy and dignity, but also in order to help us manage in the future respiratory conditions, such as we've been through in the recent past. We're doubling our resus capacity from 4 adult bays to 8. We are adding a further 2 paediatric resus bays as well. And very importantly, we decided early on in this development to ensure that our CT scanner capability is located within the department to minimise delays within for patients where currently a CT is located outside. And of course, we're building this to future standards in terms of energy efficiency and so on. I'm not going to spend any more time actually on the rest of that. I'm going to take the slides down if that's okay, and I'm going to open up to questions, I think, at that stage. So while I take the slides down, I just wonder, I can't see any hands at this stage, but Chair, back to you.
Councillor Agate, you've got a question, I think.
Thank you, Chairman. Having been over the years a fairly regular visitor with different daughters and grandsons to the emergency department, usually in a hurry, are you going to allow any more parking for people in that sort of situation than there is there at the moment? You know, you turn up with your child, and you just want somewhere to park the car and get in there quick. The current facility isn't brilliant.
So if I could just come in there then. So I won't put the slide back up because it'll take me too long technically to do that, so I won't do that. But if I could zoom in on the current designs, you'd see two things. So first of all, where the walk-in entrance is, there is a drop-off facility and a small number of spaces there. But more importantly, we have, separate to this development, we've just got planning permission for a new multi-storey car park on the north side of the site, which is a short walk from what will be this walk-in entrance past the existing emergency department, which allows us to add capacity for another 300 public car parking spaces on site. So we'll significantly, obviously, enhance our public parking provision on the site here, and that development will be in place by the end of March. So that will be something that will come ahead of the emergency department.
I'm sorry, you that wasn't the question that I asked. If I'm coming in there with one of my kids or one of my grandsons and I need somewhere to park, get them in through the door quick, I've got the time to go park in a multi-storey car park. I want to be into ED and having my child or whatever, whoever it is, attended to. And if I'm on my own, I don't have time to wander off out, because there are a number of questions that need to be asked, paper that has to be filled out, and you need, if you're in that situation, you need to be in there. So we come back to, you mentioned there would be a few parking spaces outside. My question is, are you really of the opinion that what you've allowed, and you haven't told us how many, will be adequate?
So apologies, Councillor Gate, not directly answering the question. So we are there will be some drop-off spaces outside the new walk-in entrance, which are additional to the provision that's currently for our existing emergency department, in addition to where we've already got some perimeter public car parking spaces in that vicinity, in addition to the additional 300 spaces that I've just described. We have worked with the planning officers, particularly on this point, actually, both in terms of traffic congestion, but also in terms of patients' ability to get into the emergency department and drop their vehicle, whether in exactly the circumstances you describe. So whilst I'm probably pausing on giving an exact number of additional drop-off spaces, I think it's in the order of 3 or 4. I think it's in that sort of spectrum. But certainly we have touched on this point and consider this point quite carefully with the transport officer and the planning officer as part of getting the planning permission.
Can I just make the point that I am very, very well versed in that car park that we're talking about, because I am, or perhaps when things get that, the normal very consistent visitor to ophthalmology. So I do know that area extremely well. I know how few parking spaces there are outside of the current emergency department. So it's, please would you bear this in mind, that parents in a panic need somewhere to dump their car. And I know that where you're going to build ED, there is no facility, is there?
So thank you. We'll definitely take that back. I'll certainly take that back, and as we work through the final design in the next stage, we will retest that with all parties, Councillor Gate. And of course, we are also providing, as I described, for providing staff car park, which I know is different to what you're asking, but on the floor below. And indeed, as part of the final design, there may be some opportunity to designate some of that for additional public spaces, should we feel that's needed. So we'll certainly take that back to the planning team and the clinical team. And the transport team's looking at this, so really appreciate that feedback. Thank you.
Thank you.
Thank you, Rob Wood.
Mark, really, this is just a what's keeping you awake at night thing. It looks like a great plan. It looks like going. So, what are the things that could go wrong? In other words, again, it's an opportunity just to sort of say if things go awkwardly wrong, where are the areas that you think could go awkwardly wrong? It's really, if you like, to broadcast in advance the areas that are most at risk. So having got the planning, got the funding in place, and you've got your plans, etc., what are the things that you're worried about that the public should just, be aware of?
So at this stage, I think we haven't got we still need to navigate there's two parts, I think, to answer the Councillor Wood. I think the first one is we haven't yet navigated the second, third stage completely of the business case process. So clearly that's that would be on that list. I would say that just this morning I've had the latest conversation with a group of individuals who are reviewing that business case, the outline business case, and they remain squarely positive around our progress and everything that we're assuming. So I'm less worried about that, but clearly, you know, that's always a worry. The thing at the moment that's probably keeping the project team most awake at night, I suppose, is currently we're in a period nationally where there is a shortage of construction materials and construction labour workforce. We're about to start this building project next summer. We're already experiencing some issues around this with the other developments we've got on site, although we have mitigations in place and we're managing it. But of course, if that position doesn't change nationally, then that could impact any development, and this wouldn't be insulated from that either.
Okay, I'm glad you said that, Mark, because that's what I was expecting, that it's a construction project. And I guess in the way, knowing that early, you're going to have to build in your plan B and C, and obviously telegraph that to everybody else who's, you know, may seem you've got a breeze of a project. It looks pretty on paper, but in fact, the delivery of that's going to be quite, in the current circumstances, going to be quite difficult. And I think it's always wise to telegraph that to lots of people in advance.
Thank you. Anne Briggs.
Thank you. I just would like to go back to Councillor Agate's point, because I'm a county councillor, so we've had the exciting plans at Hampshire. And as a person who uses the hospital, I'm really excited. It's something Portsmouth badly needs. But going back to Councillor Agate's question, when we were first shown the plans, one of my questions was, what are you doing about people who are told by their doctor to take the person there straight to the hospital? Don't wait for an ambulance, it's an emergency. And it's a nightmare. And I'm hoping, and we were told at the time that this is going back a year, that this would be factored into the plans. And if you can imagine, you're taking somewhere there who needs urgent treatment, and you have to park your car, you rush in, you can't find a wheelchair, you can't find anyone to help you. So I was hoping that this was already going to be factored into your plans. Thank you.
Thank you, Councillor Briggs. And so car parking we've talked about, and I've committed to revisiting the current position and revalidating or enhancing as part of the final design. In terms of our provision for portering, wheelchairs, and all of our internal arrangements once visitors, patients arrive through the department through a walk-in route or a drop-off route. That is all being taken account of as part of the design as well, and in much more detail I could probably relay on this course through designs. But again, I think the points that we're hearing here is valid feedback, and therefore absolutely take that back through the design team as part of the next stage of design. So it's always welcome to have feedback such as this. Thank you.
Thank you. I'm just disappointed that it hasn't been looked at before, because I know there's been quite a few requests, but thank you. You just need a dedicated area for that emergency, for people who've been told to get a person to the hospital as soon as possible. And may I ask one more question, please, Chairman?
Yes, certainly.
Thank you. Should this, the new plans, which obviously I've looked at, should this stop people queuing on trolleys in hallways and people being lined up in ambulances, hopefully?
Shall I take that one, Mark? It would be lovely to think so, wouldn't it? But this isn't a huge gain in additional space. What it is a provision with far greater clinical effectiveness of essentially the clinical space that we have. For those who have been into our emergency department or been admitted through that route into the hospital, you may have seen just how the layout is not effective. It's it's based on what was what's now a 30-plus-year-old emergency department that has been expanded into many different areas. So yes, of course, absolutely. The intent is that we do everything that we can do to avoid holding ambulances, but this is not just building more space so that the ambulances can offload and patients are moved in rather than outside. This is trying to make sure that the way in which clinical space is provided allows for the best possible, the most efficient and the safest treatment of patients, and all of those things are quite different to the existing department. We also know, going back to the point I made earlier, that there has been an almost inexorable trend towards more people coming to the hospital for treatment, and unless we continue to work across the community and with all the other providers in healthcare to support patients who have a health need that doesn't have to be met in the hospital through some other route, then unless we do that, we'll never have enough space. So it isn't as short-term a build or a focus on the build of just making enough space to avoid ambulance handovers, but of course that is one of the intended benefits. Yeah.
Okay, thank you very much.
Thank you. Were there any other questions? I think that was it. So, Mark, John, thank you very much for that. If there are no other questions, you're free to leave.
Thank you very much indeed, Chair.
Thank you. We'll move on to agenda item 5, which is the Hampshire and Isle of Wight Partnership of Clinical Commissioning Groups. And I'd like to invite Jane Ansell and Derek Sanderman to give their reports or give an update on their reports. Thank you.
Shall I commence, Chair?
Yes, whenever you're ready.
Derek, is that right for me to go first?
No, thank you. I think Paul was going to
oh, yes, thank you.
Start before me.
Yeah, I'll wait for Paul.
No, Jane, if you start, and then I think Paul will go next, then I will follow Paul.
Oh, super. Thank you very much. Good afternoon, and thank you, everyone, for the opportunity to update you on our Hampshire and the Isle of Wight COVID-19 response. I'm Jane Ansell, the Senior Responsible Officer for the COVID-19 vaccination programme for Hampshire and the Isle of Wight. You'll no doubt have seen the government's announcement this week regarding the COVID booster programme and the universal vaccinations of the 12 to 15-year-olds as part of the National Autumn and Winter Plan. And whilst the paper that we provided with you already does give an overview of our ongoing response, inevitably in such a fast-moving programme, a number of things have actually changed. So with your permission, I'll acknowledge that we've presented you with this paper, but I'll give you the latest position that we have to date. So it's 9 months since the COVID vaccination programme was launched across Hampshire and the Isle of Wight, and since then more than 2.6 million vaccinations have been delivered across our communities, and thanks to exceptional efforts of colleagues and partners and volunteers. We're extremely grateful to everybody who continues to support the programme locally. Vaccines have been delivered across GP-led vaccination centres, hospital hubs, the vaccination centres and the pharmacy-led services, a really broad range of offering from there. And we've been at festivals, from festivals to fire stations, cruise ships, to circuses apparently. So a very broad. Also in boxing clubs and in places of worship. Countless walk-ins, pop-ups, outreach clinics have all been there to help as many eligible people as possible to be vaccinated. We continue to work in partnership to deliver the programme across Hampshire and the Isle of Wight, ICS footprint and our targeted partnership activity and outreach work to tackle inequalities and reduce barriers for people who may be less likely to be able to take up the vaccine offer, and we continue with that work. On Tuesday, the government announced its plan for the next phase of the COVID vaccination programme, and this forms part of this wider winter strategy. Those over the age of 16 who are yet to have received their first dose will remain eligible. This continues the arrangements promised by the NHS for an evergreen offer to vaccinate anyone who previously declined the opportunity. Existing COVID-19 vaccine offer has been extended to a universal offer of a first dose of vaccine to people between the ages of 12 and 15. To date, some children aged 12 to 15 can already get vaccinated, especially if they live closely to somebody who is more likely to be liable for infection. So we did already have that in place, and that continues. The booster program is now going to be offered to anybody who was vaccinated in phase 1, and the priority groups for 1 to 9. This dose should be offered no earlier than 6 months after the second dose, and as far as possible, the booster program should be deployed in the same order as it was, but we do know there will be some enthusiasm with people rushing to get their second vaccine as soon as possible. But we'll put all the right checks and balances in place to ensure that nobody gets it before it's due. The government has said the NHS will contact people when it's their turn to receive their dose, and they'll be able to apply in the same way as they did for an appointment at a vaccination centre, or for those that need it, they will be seen by their GP. We continue really closely now to work with partners across Hampshire and the Isle of Wight footprint to prepare for winter, including the delivery of the next phase of the COVID vaccination programme and the flu vaccination, and the booster vaccination for 12 to 15-year-olds due to start next week. We are working closely with schools and are extremely grateful for our colleagues in education's support. That's the end of my summary, Chair.
Did anyone have any questions? Lynn?
Thank you, Chair. Hello, Jane. Just a couple. You're saying that the NHS will contact patients if they've already been contacted through their vaccination centres before. Will they have to travel to a different vaccination centre, or will it be hopefully at the same place that they went the first time?
If that's the most suitable place for them to get to, then we will accommodate them in the closest place. The only difference I would say, Councillor, would be that in the very early days, some vaccines were delivered at the hospitals, but we're allowing the hospitals to focus on their own staff so that they can continue with their plans for winter and protecting those who need urgent care. So we will be directing some of those patients to local vaccination centres.
Lovely, thank you. And just another one with the flu jabs, obviously coming up as well.
Yes.
Is there a time space between them, or can they be done together? Or do they have to wait 2 weeks before they have the COVID booster?
No, fondly known colloquially on the team as co-administration, and I know Ms. Derek will be able to add more technical information to this, but co-administration is permitted. The Chief Medical Officer has described people having a vaccine in each arm. So wherever possible, we will be co-administering.
Lovely, thank you.
Thank you. Is there any other questions? If there's not, Derek, would you like to present next?
So Paul was going to do an introduction about the Hampshire Isle of Wight strategy, and then I was going to follow on about population health.
Okay, no problem. Over to you, Paul.
Thank you very much. So I'm Paul Gray. I'm Director of Strategy at the Hampshire and Isle of Wight Integrated Care System, and Derek is with me today, and also Joe York is with us. I know that you've met Richard Samuel many times in the past. Richard is leading integrated care system development in Hampshire and Isle of Wight, and Richard has moved on to a national role, and I've taken Richard's leadership role, so hence my joining you today. The paper that's in the pack today describes some of the technical changes that are happening nationally as the Health and Care Bill makes its way through Parliament, and I'm not going to repeat the detail that's in there. We can come back to that and answer questions on that. But I did just want to say two things, because I think the obvious question out of all this is, so what? How does this help residents in Portsmouth with their care? And there's just two things I wanted to add on this. So the first is that I think we in the NHS really do welcome the introduction of the Health and Care Bill, because taking away more of the barriers to joining up care within the NHS and between the NHS and local government is good news, and will help us to more seamlessly plan and join up services on the ground for residents. And the second thing that I wanted to say is that the Health and Care Bill and the changes that are happening are about building on the arrangements that we have now and going further, not unpicking any of the arrangements that we have. Portsmouth, through Health and Care Portsmouth, has already got deep levels of integration between NHS and local government, and this is about doing more not unpicking or doing any of that. So for those two reasons, we welcome these changes, but it is important that we recognise that there are structural changes going on as a result of the new Health and Care Bill. In the notes of the last scrutiny panel, we were, and in the conversation that you had in June, we were very conscious that there was also a request for an update on population health management. And so Derek Sanderman, who's Chief Medical Officer in the ICS, has joined me and is just going to say a few words on that before we open up for any questions that you might have. So thank you, Derek.
Thank you for your patience to let me talk a little bit about this. I fear I might be teaching my grandmother to suck eggs, as it's so crucial to everything you do. And I don't need to say that the health and well-being of our population is central to everything we're trying to deliver. And it's one of the big differences that we hope the ICS will make. One of the things that we're charged with is walking alongside you more strongly and trying to engage in the health of the population rather than just treat illness. And so we hope to see a big change. And here, it's not just our story, but the story of us all needs to be much better. And I think it sits on our shoulders. And we will have conversations, I'm sure, through the Health and Wellbeing Boards, but maybe more conversations than that, because I think the challenges are huge. So why do I say we have to be better? And it's simply the last 6 decades, we've had just improving health. And that's, on a macro level, has added 10 years to life expectancy across the board. And you can sit fairly proud on that, because the evidence is 80% of that is from the wider terms of health. That's poverty, housing and the like. And about 20% is a contribution of health, vaccinations, or the treatments are delivered. So the most effective part to date has been the things that you've led. And I should say, I think that will continue. If we look at the real problems for us, the real opportunities sit in that order, but we both have a role to play in all of this. So why a good story so far, what is the problem? And the truth is it's stalled. In fact, the life expectancy gains have started going backwards in those areas of inequality, but it's stalled everywhere and it started going backwards. And the health of our population is visibly poor. We've really slipped back as a country. And I'd summarize it. If you take those 10 added years, they're spoiled. Too often they're spent in poor health, where that health profoundly and negatively impacts on well-being and happiness. And that's a really true message. And it's creating a lot of work for all of us and actually spoiling the benefits that we've done. And I think it's becoming a problem. So in describing that briefly, and I could talk much more about it, think about what we need to do and how we look at it. And I suppose I start on two levels and from two lenses. There's a macro lens and there's a micro lens. And I'm just going to describe what I mean by that in the macro lens. Is if we looked from space and we looked at the world and looked at health inequalities, what would come across for us in our population is that we're doing really badly from two things. One is our general well-being in terms of our weight, our obesity, our lack of activity, and that is contributing to huge morbidity. So it contributes obviously to diabetes, heart disease, stroke, dementia, cancer. All of those are linked to that epidemic of obesity, and it is the epidemic we were dealing with before the current one, and it's going to come back and be a problem for us. And the second one for me that I think is really important is particulate matter and pollution. And I think we focus too little on this. And I liken this a bit to climate change. That there's a period in the heydays of the 1950s where we were unworried about pollution. We were innocent. We're now going to be judged by our children at how we react when we're aware. Particulates the same, but actually particulates might be the one thing they look back at us and say we really failed them, because they're being exposed to particulates throughout their life. And just to put that into context, it's equivalent to smoking 20 cigarettes a day, the pollution that we're putting in particulates into our environment locally. And that's starting that from in utero. So because of particulates, fetuses' lungs are developing less well than they were. Just to give an example of the impact starts early in life, and we're exposing people to that. So from an upper level, there's a real challenge. And if I go back to the challenge the Victorians faced, I think we together face a similar problem if we're going to really, really make a difference to the health and well-being of our population. But I want to talk about a second bit and talk a bit more about what we're doing, because the other issue relates to inequalities, the individual risks that people have, and so much of the things that we can do in health to help our population. And here we've started, and we started by investing in infrastructure. So we've engaged two companies. One is Cerner, and they're to help us mine and accumulate our data and provide data to clinicians in which they can ask questions, so they can look and see who are the people attending hospitals, who are the people coming to harm in mental health, and start identifying those. And the second thing, when they identified those, it allows them to move from a reactive health service, which is what we have now, to a proactive one. How do we see those people at risk and start getting behind them, going upstream to reduce the risk and treat them? We're also working with Optum, because asking those questions and knowing how to intervene is not natural to our clinicians. We've not done this. And so this is a company that's sort of working with us to teach predominantly primary care physicians on how to use this information and how to make the improvements and how to support their populations going forward. I went to the first rollout meeting for the first groups, and this is being trialled in North Hampshire and locally in South East Hampshire with some primary care teams. And actually the enthusiasm was really strong. They were very excited to be engaged. They couldn't wait to get going. They wanted to see how they could use this to start helping their population. So we've had the first session, a QI session, quality improvement or continuous improvement to come from business as an approach to see how we can help our GPs understand their population, see those at risk, and get upstream and try and help them and look after them. The intention in that is to look after all aspects of health, prevention, inequalities, and also start looking at wellness as well as illness, to look at psychiatric morbidity and illness. So the teams have started, the program started at that level. As I started, and I suppose in my introduction, there's a huge amount that we need to do, and how we engage and how we have those conversations together, I think is going to be the thing that marks our success going forward. So I'll pause at that moment.
Thank you. Were there any questions? No? Councillor Briggs. Councillor Briggs.
Thank you. It does help if I unmute. Thank you. That was really interesting. I think the work you're doing is vital, because when I was asking the last question, will we have queues of ambulances outside the new ED? We don't want them, because our work is prevention. And until we sort this out, and it was quite frightening to say that what you've just said about pollution and unborn babies, we're not doing a very good job, are we? And we just want to do more that we can to prevent this. So it's just a comment that I think what you're trying to do is vital on our way forward for the health and well-being of the population. And we do need for people, I think, perhaps to take more interest in their own health and well-being. And whether it's for doctors to put them over to them, I don't know. But thank you for what you're doing. It was just a comment.
So thank you for your comment. And I just say we're going to have to do this together. It's going to be both of us, all of us, that will make the difference. So how we walk along together is going to make the difference. You're absolutely right. Prevention. So much of I was a physician, and I would see patients with a stroke for which I had so little to offer, and yet it was a preventable disease, or at least preventable in a large number. We have to change our approach.
Yes, I agree with you. Thank you.
Thank you. Councillor Wood.
Derek, it's brilliant what you're doing. And in the past, I've had the cabinet posts twice for children education and children and young people. So it's in the blood, if you like, in recent years about trying to deal. And we've tried to deal with these things like health and well-being and obesity. As we get older, we can say these things, we can do empirical studies, and we know that's the issue. It's really communicating that where it's effective. Now, one of the things I really feel we strongly need to understand is the younger generation coming through. We talked about it earlier before this meeting, about social media, influencers, etc. This is the bit we fail to understand, which is you've got to get to the young people to make that change and that influence. And I think one of the things that we strongly, as established enterprise and established base of knowledge and knowing what should be better, is to actually look at the up and coming ways of communicating with them. It's about engaging maybe the Googles or the what have you, who have all these sort of platforms who our youngsters are using, because it is even if you get to the schools, and you know, I had the schools in education, teachers telling you what's good for you is great, etc., and teach you that. Ultimately, at the end of the day, it's the peer group and what people see around them. And the factor for that, I would say, is much of the obesity we know is things like going for fast food in some summer areas where basically these big firms have a great advantage over us in the fact that their media presence and ability to affect young people's behavior is tremendous. So young people are just simply drawn to a gravity well of things in society that are not good for them, and somehow we have to take all this knowledge and this thing and compete on the same ground. So that's one of the things I will say, that somewhere along the line, governments or whoever need to take, for sure, you need to compete on the same ground. You need to have your influencers in the same territory. And that's the real crux of the issue.
So thank you. And I'd agree with everything you say. It's about changing behavior. Joe's put in the commentary that this is happening with public health and locally. And, you know, most of this will happen locally. That's where it needs to happen. I'll just challenge us a bit more, because you're right around industry and food. The root of our obesity epidemic is our inactivity. We actually eat less per head of population now than we did in the 1950s when obesity didn't exist. We've become very sedentary. And, you know, doctors tell people, and have been telling for the last 20 years, what you should eat. Dietitians have, the politicians have. It doesn't change behavior. And the countries that have succeeded have taken much more bold issues. It's a bit like seatbelts. People knew they should wear seatbelts. It took legislation to make us adopt it. And our challenge is that being active in our lifestyle to an active transport policy is not easy. And the countries that have succeeded where we failed have really made it easier to cycle around a city than to drive around a city. And I don't think if that's the Victorian challenge I'm putting, that's the challenge I'm saying we have to do really well. And so that's it for me. It's all of us. How brave are we going to be to try and look after our future health?
Yeah, Chair, if I can just add one, you have a very good point about the physical activity, and that has been a bugbear of mine, that with having had the education thing, looking at private schools and state schools, private schools encourage competitiveness on the field, competitiveness in sport and all those sort of things. If you look at the public sector, their fields are residing like there's no tomorrow. Their access to things like swimming is being reduced because of the public realm doesn't give them that easy access. And I think in the way that's also a very important point, which is the agenda for physical sport in schools has also got to be helped, especially for the majority of children who won't be able to go to private schools where they've got these facilities. And that's a real problem, which is you need that competitiveness for people, young people, to feel like they're, you know, out there. I agree.
I agree. These are our challenges, aren't they?
Thank you. Councillor Hook?
Thank you, Chair. Just a quick comment. I agree, communication is the key here. We need to get that out, not only to the young people, but we also somehow need to get the older generation in through the doors again. We're finding, certainly over here, not all doctors' surgeries are willing to open. And to get that message out, you have to be open so they know what the message is. And I think that, you know, we've got a great problem with doctors not reopening as they should do. It was great doing the e-consults during COVID. We've said this before, it was fantastic. but we need to go back, or the public need to know what's happening. If it's not going to return, that they need to or can see a doctor when they need one.
Thank you, Lynn. And I think it's a really important challenge and challenge for primary care. How do they balance the e-consult, which is consuming their time, versus the need for face-to-face? And I don't think we've got that right yet. So, it is something we're talking about, and you're absolutely right.
Thank you. Councillor Agate.
Thank you, Chairman. The bottom line to this really is education, isn't it? I mean, people have got to be led down the road that will lead to where we want them to be. I keep referring to my grandsons, both of whom have suddenly realised that they're not really obese, but they are overweight. One of whom is because he's losing 3 seconds a lap when he's racing karts at a 24-hour event. And the other one who's finding that although he's 6'3", he needs to bulk up a bit to play more effective rugby, both of whom have been to and go to private schools. So, but the education is coming through that they need to do something about this to achieve what they want, and everything comes back to education in the end. You've got to be led.
Thank you. Did you have anything extra to add, Derek, Paul?
No, thank you very much. Good to talk to you all.
And just say no, thank you. And I do think it'd be useful to continue these conversations and, think about how we widen them out to really make meaning from them.
Absolutely. Thank you. Paul, you were down as agenda item 6, but I think you've covered everything, haven't you?
Yes, thank you.
Perfect, thank you. You're free to go, or you can hang around for the rest of the meeting if you want. And I'd like to move on to item 7, public health, and invite Helen Atkinson to give us an update.
Thank you very much, Chair. It nicely, I think, flows from the update that Derek's just given, because as normally we come every 6 months and we just do give you an update on current Public Health Commission services and delivered services that we are leading on within Portsmouth City Council Public Health Team. But I do want to stress all of the work we do is in partnership, not only with other directorates within the council, but obviously also work very, very closely with Joe and the team in Portsmouth City CCG, particularly through the Health and Care Partnership. I mean, everything Derek's just talked is it's very much heartfelt for me. I've been working in public health for many, many years, and which can be seen both ways, I think, because we have been obviously leading and lobbying the health improvement and population health approach, which Derek very ably just presented there and discussed. I suppose you could argue, well, public health been working on this agenda for very many years. Why have we not been successful? Why are we still dealing with these issues in terms of inequalities? And why is some of the points that Derek makes very ably, we're not seeing huge improvement? And I think this is the complexity of the agenda. So as an example, we've just been talking about obesity. It's something we've been talking to QA about in terms of the fact, just to give you some examples, there were some really good examples there about the fantastic work that the Acute Trust do. But, if we look at COVID in the last 18 months, when you look at who's in, because I want to make that link, when you look at who's in intensive care, with COVID, it's obviously now what we're seeing is unvaccinated people, but all the way through we have seen health determinants like obesity, diabetes be a factor in terms of a higher risk for being hospitalised and ending up in ITU. So all of these are really important points because for instance, if we look back 70, 80 years, people would have died from infectious disease, but now with the fantastic science and technology developments in the NHS, what we are tending to see now is people who become unwell and have a greater need for healthcare and also for social care for people or lifestyles. And these are really complex things to deal with. And there's a huge inequality because we see greater inequalities of health outcomes in more deprived areas. So not to get onto my public health bandwagon, but these are very complex issues that need to be tackled in partnership, and both at a international, national, regional and local level. So when we look at obesity, I do agree with Councillor O'Gate that, you know, obviously education is really important, but it doesn't tackle obesity alone. You have to look at national policy, you have to look at marketing and how the food industry works. There are so many factors which I know Councillor Wood is very aware of in education. You know, so we do market a lot of unhealthy behaviours and poor diet come from being as a population being marketed to, you know, eat unhealthily, you know, because that's particularly, I think, in children in terms of things like fast food and all of the unhealthy. And I'll end there on that particular note. It's just, as you were discussing it, it was an opportunity for me. So I just would like to, building on what Derek has said, I just want to mention, and then I'm happy to take any questions on the presentation, which is more the kind of operational detail. I just want to mention that there is a huge amount of work, and I'm afraid I can't necessarily speak on behalf, because I know we've got councillors here who are from Hampshire and surrounding Portsmouth, but in Portsmouth we have got a very strong partnership approach to how we tackle the health and wellbeing agenda. We're currently refreshing our health and wellbeing strategy through the Health and Wellbeing Board, which then leads into the Health and Care Portsmouth delivery plan. But it's very much a partnership approach, and we are very much focusing on what we call the wider determinants of health that Derek mentioned, or the underlying reasons people become ill. So the main focus of and I'm sure at some point we will come back to the HOSP with a presentation on health and wellbeing strategy if you would like, but it's very much a focus on actually tackling those underlying issues of poverty, of education, of employment, etc. So real focus and really good work already happening, but more to be done as we move forward. But it includes all of the partners on the Health and Wellbeing Board. So that is the NHS locally, it is obviously the council, but it's also includes the police, business, the university and other partners on that board. But some really good work, particularly the focus also on air quality. And currently we're working, just because we talked about that today, we're currently working, and it is in the presentation, I think, that with QA as well as other NHS providers. So as an example, we know that around 10%, and this has come from the Royal College of Physicians, of journeys made in the car are often related to health, either going for health appointments or those that work in the health service going to work, or people visiting hospitals, etc. So we're looking at how we can work with QA, and that work's already underway, to try to reduce the traffic. I know that's not going to be, a lot of people aren't going to enjoy that, because that then relates to parking, but obviously it's how we actually make it easier. So it's that what we call the nudge theory in public health. How do you make it easier for people to make the right choices? And so therefore, if you want people to come out of their cars and move more, you have to make it the best and easiest choice for them to do. So lots of work going on at the Health and Wellbeing Board on that. So I just want to say some really positive partnership working going on at the moment. So then back, sorry, because I know we're running late already, but back to the presentation, you'll see I've covered updates within the presentation on a lot of the work that we do within public health. So I'm happy to take any of the questions on that, but could I also just mention, I think, what everybody else has said, we are very much still in COVID response mode. we are now, it's almost harder, I would argue, than at the beginning of last year for us. I recognise it's going to be different for different responders to COVID, but we're also having to do our business as usual in terms of all of the services that we need to continue with, like our sexual health services, our substance misuse services, how we work with the homeless, how we support education, etc. But we're also still very much in full response mode. So we're delivering, which you'll see from the presentation, the all of the what we call the asymptomatic testing for COVID in the city, as well as quite the majority of the contact tracing now. So local authorities are doing much more of the contact tracing than the national NHS test and trace now, as well as supporting our colleagues. I know we've lost Jane, but supporting our colleagues, particularly around vaccination in our more deprived communities and our inequalities groups. So had some really good success there. For example, we were one of the first areas in the country to prioritise, slightly just before the government guidance agreed with us to do this. But I want to thank Derek, Jane and the vaccination cell in Hampshire and Isle of Wight, because they've really supported us to actually reach out and target. So we vaccinated a quite high majority of our homeless population, and the work that went on to bring our homeless population into accommodation really not only supported us to vaccinate and against COVID, but also it gave us the opportunity to do work with QA to do a lot of the screening, so hepatitis, bloodborne viruses and TB screening, and we identified in our homeless population who are very vulnerable to some of these health issues, identified people that then could be treated and supported through some of those illnesses. So some really successful work, I think, by working in partnership both with our NHS colleagues, but also other colleagues within the council, like our housing department, and obviously work very closely with children's schools, education, adult social care. And I would like to say this year's annual public health report, which will be going to the next Health and Wellbeing Board next week, really gives an idea of how we've focused on our COVID response in partnership. We have had, we've had, I would like to say, for a deprived city area, we've had some fantastic work going on in communities with our strong working with the Hive in terms of supporting people through COVID. We've also ensuring that people have to self-isolate, have had access to food packages and also other support. But I would argue we were part of a study looking at lower transmission. And even though we've had times when we've had quite high infection rates in Portsmouth, we've had very few major outbreaks. Both in our, and I know that we've still got Jo, she might like to come in, but we've worked really closely across the CCG and adult social care to support our care homes around infection prevention and control, advice and training. We have had, since the first wave, we've had actually very few outbreaks in our care homes. And I'd like to thank our care homes and the fantastic staff in those care homes who've worked incredibly hard to protect our most vulnerable care home residents. We've had, actually, I'd like to also say, fewer outbreaks in our schools, although it's also been quite a busy couple of weeks in schools since the schools went back, and lots of local input and support to our schools to manage the cases that they've had, and they've done a fantastic job. We've been meeting with schools every single week with education, and they've been doing a fantastic job in schools. So again, really important partnership work, and we are expecting to continue. I think it's much as Jane said, vaccination will become business as usual with the third booster for COVID. I think testing and contact tracing is likely to be part of our world in the City Council probably for the next year at least. So lots of activity both in the COVID world and also in the other areas. And I think we've also just lastly want to mention the work that's been done to ensure that everybody is kept up to date in terms of the intelligence and insight for COVID response. That's really been important, I think. I hope Jo would agree. Every meeting that we've started in the CCG and in the council has always started with an update on the intelligence and insight. So people really know where we are in terms of the infection rates, and what the evidence is suggesting in terms of response. So I'll probably finish there because I've said a lot. Thank you, Chair.
Thank you, Helen. I think we had a question from Lynn.
Thank you, Chair. It's actually not a question, it's just a comment to say absolutely, presentations so far have been, really informative. But unfortunately, I do have to leave the meeting and carry on with my duties in Gosport.
No,
so
thank you.
Continue with a very good meeting. Thank you.
Thank you. Did anyone else have any questions for Helen or Joe? No, thank you very much then. We'll move on to item 8 on the agenda, NHS Southern Health Foundation Trust. If Nikki Crichton-Young could give us a brief update and let us know if anything's changed since the report came out.
Hi, yes, thank you, Chair. So the report itself refers primarily for us to a number of projects and to give you an update of a number of pieces of work that are going on within Southern Health. I thought it'd just be helpful, just in terms of a bit of context for you at the start of the meeting, given the, the challenges that we're all hearing about, and we've heard from colleagues within Portsmouth Hospital as well, to just give a positive message from the information we've provided around our COVID vaccination position of our staff is at 92% fully vaccinated, which is a really good position across our South East workforce. I know you've got attached the appendix and the detail across the whole of Southern, but I thought it was quite helpful for you to see the South East specific information, and not dissimilar to what Chief Medical Officer John Knighton was reporting in terms of PHU. Our sickness position due to COVID and our absences is significantly low. In fact, the report I've just received today in terms of workforce with COVID absence is down to 5 staff this month, and it was 7 last month out of a workforce of 1,352. So I just thought that was helpful, just to give you a bit of context. Having said all this, naturally, our staff are feeling particularly challenged and stretched on all levels across our community workforce at the moment. And, a lot of the acuity that we're seeing across our community services is significantly higher, understandably, given the challenging presentations that we're hearing and the situation in terms of flow through for patients to acute hospitals. So happy to provide some more data on that for you at a later time. It's something we're trying to work on across our organisation to be able to show much more visibility really of the complexities and the changes in presentations that our community services are working on. If I just take you then to our briefing report, and the key areas worth noting is the really positive news around Gosport War Memorial Hospital. Firstly, the changes that have been done on our older people's mental health ward following significant national investment, and that's eradicated the dormitories on that ward. We had the official launch in the, I can't remember exactly when it was now, it seems ages ago, but earlier on in the year, to be able to reopen our ward, and we're now presenting the work is ongoing on the second ward. So that work should be completed around the end of November, and that is still on plan. It has been delayed slightly, if any of you are aware of the original timescales, and that's purely due to numbers of contractors able to be on site in terms of COVID regulations. So some of that impacted earlier on, which has had a knock-on effect. But what we're receiving is some really positive responses following the official opening by the Mayor of Gosport and the Lord Lieutenant of Hampshire. And we've actually been asked to present the changes that have happened on our ward nationally, because it's been recognised, which is really good news. And happy to encourage anybody to link onto the website, which is included in our briefing, to get some of the details around our 2 particular older people's mental health wards in Gosport. That's enabled us, whilst we've been doing that work, to do some broader work in our hospital in Gosport and improve the accommodation, so we've got more single rooms that are supporting the complexities that COVID brings in our community inpatient units for adult services. So that's just worth noting, because that's a really good news story. It's also meant that the previous community inpatient ward is now being able to be used by our community nursing and therapy teams to focus on rapid assessment work and support people in the community, which again, increasing the capacity to be able to do that at scale in a specific area at greatest need, linked to the UTC at Gosport Hospital and all of the other provisions, is working really well. And that work was actually completed in May this year. The other part for noting, and I know there was some questions earlier in relation to the urgent treatment centre. So the urgent treatment centre, which was previously the MIU in Petersfield, went live in the summer. We have had some difficulties across all of the urgent treatment centres, as has already been spoken about, but I'm pleased to say, with the exception of 2 specific days in Petersfield Hospital, they've been able to maintain business as usual and run an 8 to 8 service. So whilst there are some challenges across our urgent treatment centres and the staffing, we're working collaboratively how we can manage those issues. But for Petersfield specifically, we've been able to remain open and fully work as business as usual, with the exception of 2 days that were earlier in August. In relation to the Willow Group, it's worth noting the GP survey that was published, and the recognition that there were some low scores in specific areas. We're working really closely across the partnership, the primary care network, with CQC and all of the GP colleagues to be able to address some of those concerns. A thing that needs to be recognised with the Willow Group is obviously the scale of that, being a number of practices that are together, and the work that's been done with the Willow Group and the CCG with the primary care networks in Gosport to work together as one primary care network is working really positively, and we're getting some really positive responses from that. Eating disorder service continues to be particularly challenging nationally. I won't talk about the children's aspect of it, because that's not the service we run in Southern Health. But in terms of the adult services, we're continuing to work with Dorset and the wider Hampshire and Isle of Wight, provide a collaborative partnership to get the model right for eating disorder services. It does impact on the acute system in terms of often we have 1 or 2 patients sat within PHU who need to be in one of our national eating disorder beds. So it is a recognised national challenge, but something that we're all very engaged in addressing and working forward to seek a resolution across Hampshire and the Isle of Wight. Just to share some of the work and confirm now the national investment around mental health transformation, and particularly the focus around the no wrong door principles. We've gone out to recruitment now with our primary care partners for those joint funded split posts that primarily are in Gosport Central, Gosport West and Strawberry Hill, and they're the initial ones, and then others will follow. And then finally, if I may, because I'm aware from members previously when I've joined this meeting, we've talked about some of the system pressures, and Clarence as one of the out of hospital solutions. Just to give you an update that in terms of preparation for winter, we're looking at how we can increase the numbers of beds in Clarence unit, and Southern Health, as colleagues of Hampshire County Council who lead this, are working to recruit healthcare support workers on their behalf to enable that to progress further. And finally, the only thing I would say is that the PASCO report is now out. It was published last week, and I know my Chief Executive, Ron Shields, has asked to meet with relevant members of scrutiny panels to be able to go through the report in more detail and address some of the recommendations. So I'm not planning to do that today, recognising it's just new out, and Ron, as our chief exec, who wasn't able to attend today, wants to make sure he has the opportunity to do that with you all as appropriate. Is there any questions that anybody would like to ask?
Thank you, Nikki. I think Councillor Agate, you had a question.
Comment, really, Chairman. Thank you for that report, and particularly regarding Petersfield UTC. And we were advised by an earlier speaker about the staffing problems, but you think that that's totally in hand now, which is great. I must admit I had to go up for an X-ray last week, so I asked them, did they have all their new equipment? They said yes. But your doctor should have the result in about 10 days' time. You think, wow, internal communication is obviously not too brilliant. And I couple this with the fact that QA are also obviously having internal problems with cancelling appointments and then ringing up my wife and asking her why she hasn't turned up for an appointment. So, could you ask you to perhaps have a look at the internal communications within these establishments? It would certainly save wasting an awful lot of my time, my wife's, car parking staff, the staff within oncology, and places like that. Thank you.
Thank you. I'm certainly happy to take that away to the provider collaborative that are discussing the UTCs across all 3 sites and that relationship with Portsmouth hospitals and primary care. So I will certainly take that back to them, and that's useful insight. So thank you.
Thank you. If there are no more questions for anyone, I think that's the end of the meeting then. Can everyone note that the next meeting is scheduled for Thursday, the 18th of November at 1:30? And can I just remind people not to say anything at the moment until the live stream's switched off? But thank you for everyone, and sorry for the delays earlier.
Yeah, okay. I'll switch it off now, and again, apologies for the delayed start, but you'll still be audible for a couple of minutes.
No problem. Thank you.
Well, I enjoyed that. That was a really good meeting.
It was, yeah.